Okay. So first we have to diagnose that the patient is pregnant, right? Positive urine pregnancy test. We have a qualitative test, which is what this is. We also have a quantitative test that's done by blood. Important to note that in contrast to the infertility tests, any second line here is considered pregnant. Even the faintest of lines is considered pregnant. Positive 4 weeks post LMP, although there are lots of tests out there that promise early detection. There's no harm in trying an early detection, more like 10 days post ovulation, but very often you'll get false negatives. So you can also have a serum pregnancy test. This measures the beta HCG in the serum, and it can be qualitative or quantitative. It can pick up a pregnancy slightly sooner than a urine pregnancy test, but really the urine pregnancy tests are getting so good now that we don't even perform the qualitative tests to determine pregnancy at this point. We really wait until those urine tests are positive. So here's a chart that I do not want you to memorize. The only level that you really need to know is these top two levels, or are these top two levels. So if you do a quantitative test for whatever reason, and you get a measurement of less than 5, then the patient's not pregnant. Anywhere from 5 to 25, the patient is pregnant. And then you can see as we move from week to week, the values vary greatly, but with each week of pregnancy, you want to start to see a doubling of numbers in the first few weeks of pregnancy, and then those numbers really start to shoot up as you move into the 3rd, 4th, 5th, 6th week of pregnancy. We can also do a transabdominal or transvaginal ultrasound, and what we're looking for is the gestational sac, and this can be visualized between 4.5 and 5 weeks gestation. We start to see cardiac activity, so those cells that are going to become the heart will start to actually beat between 5.5 and 6 weeks. Quickening is a term that you need to know. I think we discussed it earlier. This is a patient's initial perception of fetal movements. It can feel different to every patient. Some patients describe it as a feeling of butterflies in the stomach. Some patients will describe it as a sense of just tightening in the stomach. It's something that patients typically feel in a first pregnancy between 16 and 20 weeks, and you'll see those numbers again. Although subsequent pregnancy patients will typically feel quickening earlier because they know what to feel for. We can also check fetal heart tones with external Doppler at 10 to 12 weeks. And this is just done by placing the fetal heart monitor on the belly, very, very low in early pregnancy, so low that you feel like you're kind of pushing into and under the pubic symphysis, and that's done, again, you should be able to hear those heart tones by 10 to 12 weeks. It's a really exciting time for a new mama. Some signs that you need to know for pregnancy, some things that you will see again. Chadwick's sign, which is a bluish discoloration of the cervix, vagina, and labia, and this is just from venous congestion. This occurs at 8 to 12 weeks. Hagar's sign, the cervix begins to soften at about 6 weeks. So on our initial visit for patients, our history is going to include an obstetric history. We've talked extensively about that, a past medical history, diets, medication, tobacco, alcohol, illicit drug use, all important things to ask patients. You want to make sure that they understand how important eating well is how important it is to discuss medications they may be taking with you and or their primary care provider, and how important it is to not drink or smoke or do any illicit drugs while they're pregnant. They're affecting not only themselves, but they're affecting the fetus as well. Risk assessment refers to primarily safety in the home. Does the patient feel safe at home? Is there any domestic violence present? And then obviously we'll do a physical exam. A laboratory test done at this first visit is going to be an RH type, an antibody screen, and this lets us know whether or not later on down the road we're going to need to administer RhoGAM. Hematocrit, or hemoglobin and mean corpuscular volume also need to be looked at. You may want to do cervical cytology, certainly in women who are age 21 or older. Pap smear is perfectly okay to do during pregnancy. Urine culture, syphilis testing, hepatitis B antigen testing, chlamydia testing, and thyroid function testing are all pretty typical initial labs to determine. Determining gestational age, you should know how to do this manually or in your head using Nigel's rule, which we talked about briefly, I believe. You take your LMP, add a year, and subtract 3 months, and then add 7 days. Usually you'll have one of these handy-dandy charts where you can actually pinpoint the day of the missed period, and it will tell you when the patient likely conceived. You start here by looking at the first day of the last period. Then you can tell when the patient likely conceived. Then you can tell the missed period. And then all the way around here will tell you when the patient is due. A normal pregnancy lasts anywhere from 38 to 42 weeks. So determining gestational age by ultrasound. This is going to be most accurate within the first 1 to 2 weeks of the first trimester. As we move into second and third trimester, it becomes less accurate. So in the first trimester, it is accurate at up to 1 to 2 weeks. In the second trimester, it's accurate to about 2 weeks. In the third trimester, accurate to about 2 to 3 weeks. Office visits. Patients should have office visits every 4 weeks until 32 weeks, every 2 weeks from 32 to 36 weeks, and weekly thereafter. That is something that you need to know, as is the next set of questions. So at every visit, you're going to ask about vaginal bleeding and discharge, nausea and vomiting, any pain with urination, and after quickening, you're going to want to know about decreased fetal movements. We're going to do a urine dip for glucose and protein at every visit. A physical exam at every prenatal visit. So we're going to look at maternal blood pressure, we're going to look at weight gain, and we're going to assess for edema. With regards to weight gain, 25 to 35 pounds is advisable. If you're underweight, gaining a little more than that is reasonable. If you're overweight, gaining less than that is advisable. When evaluating for edema, facial edema is much more worrisome than dependent hand and foot edema. Most pregnant women, especially as they move toward the end of the pregnancy, are going to have a significant amount of pedal edema if they do much standing at all. So we do things for that, like TED hose and advising the patient to lay down and put their feet up, but the facial edema is much more worrisome and indicative of a problem than the dependent edema is. Obstetric physical findings. Until 18 to 20 weeks, we're going to assess uterine size by pelvic exam, and we're going to state this as week size, so a 12-week uterus, a 16-week uterus, and you'll just get used to those. There's no way to teach you what a 16-week uterus feels like. But every chance you get to palpate a uterus, do it. So you're doing a bimanual exam, pressing up on the fundus, pressing down on the belly, and feeling for the top of the fundus to determine where the fundus lies. After 20 weeks, you can measure fundal height using a measuring tape. So we measure from the pubic symphysis all the way up to the fundus, and again, you're going to press down on the top of that belly to find the fundus, and measure all the way from the pubic bone to the very top of the fundus of the uterus. Obstetrical physical exam findings, measuring fetal heart rate tones via external Doppler. Our normal normal parameters for fetal heart tones are 120 to 160, a number that will come back to haunt you, so please memorize it. After 34 weeks, you can palpate for fetal presentation. So cephalic presentation, the head is down, and a breech presentation, the bottom is down. Now, it gets a little bit tricky to tell, but very generally speaking, the head is hard, the bottom is soft. So you want to determine which way the patient or the baby is lying. Prenatal labs and screening tests. So we'll screen, we'll do a Nuchal Translucency screen and a Chorionic Villus sampling if the patient chooses at 10 to 13 weeks. Quad screen is a standard test done between 15 and 18 weeks, and amniocentesis is an optional test. Between 18 and 20 weeks, we do a routine ultrasound. At 28 weeks, we screen for gestational diabetes, and we check a hemoglobin and hematocrit. At 35 weeks, we do a vaginal rectal culture for group B strep and check hemoglobin and hematocrit again. So looking at these tests in turn, first trimester nuchal lucency test, you can see the lucent zone in the neck, in the posterior neck here. Enlargement of this space in the posterior neck is associated with an increase in risk of Down syndrome, as well as some other fetal abnormalities. The chorionic villus sampling, again, is optional for the patient for prenatal diagnosis of genetic disorders, for example, Down syndrome. We take samples of the placenta for chromosomal or DNA analysis. It gives us the same information as an amniocentesis, but earlier. Faster is probably not the most appropriate word there, earlier. The problem with chorionic villus sampling is that it carries a higher risk for miscarriage within 30 days. So the patient has to weigh the risk of waiting to do the amniocentesis or doing the chorionic villus sampling and increasing the risk for fetal loss. Now, it is safer than early amniocentesis. So as you can see from the chart here, we want to wait 15 to 18 weeks to do that amniocentesis, but we can do the chorionic villus sampling as early as 10 to 13 weeks. So when we look at chorionic villus sampling, you can see this transcervical technique. The physician guides a cannula into the chorionic villi through the vagina and into the placenta under ultrasound guidance, and we take samples of the chorionic villi. We can also do this transabdominally, and then the quad screen. Again, a pretty standard test, Down syndrome screening primarily. We're measuring various fetoplacental markers in maternal syndrome. In Down syndrome, alpha fetoprotein levels and unconjugated estriol levels are going to be reduced, and the human chorionic gonadotropin and inhibin A levels are going to be increased. So that's something that you should be familiar with. So for amniocentesis, we're actually moving through the belly, taking amniotic fluid from the uterine cavity using a needle, and again, it's through a transabdominal approach. I have a story of a gentleman who was watching his wife have an amniocentesis, and as the doctor was inserting the needle into the belly of pregnant mama, Dad started to feel woozy and started to pass out and fall forward toward the needle, which is not a good thing. If you can see how close that needle is to the fetus. We don't want to puncture the fetus. So in some act of heroism, the doctor steadies the needle and pushes the father away. He lands on the ground unharmed, and then the doctor proceeds to complete the amniocentesis. So, as you might have guessed, that's a bit of a personal story. So amniocentesis technically possible after 11 weeks, but procedures performed before 15 weeks are associated with a higher fetal loss. Common indications here are prenatal genetic studies, assessment of fetal lung maturity, and reports of fetal loss. When amniocentesis is done at the appropriate time, ranges from about 1 in 100 to a 1 in 1,000. So our routine ultrasound here, mom and dad are wanting to hear heart rate and wanting to take a peek at little one to see if he or she is smiling, and most importantly, they want to know whether it's a boy or a girl. That's not what we're looking for. We're looking for fetal number, so trying to figure out if, surprise, you have twins. We're also looking at fetal biometry, which is measurement of fetal dimensions to estimate fetal age and weight. We're taking a look at fetal presentation, so is baby head down or bottom down? We're documenting fetal cardiac activity, making sure we're regular rate and rhythms. There's no abnormalities on the EKG. Taking a look at the placental appearance, is it sufficient, and the location. A low-lying placenta can cause problems late in pregnancy. Typically, when these ultrasounds are done, we don't worry too much about a low-lying placenta unless the patient's having some vaginal bleeding. And a lot of times the placenta will migrate up towards the top of the fundus of the uterus before delivery. So we also want to assess whether there's ample amniotic fluid volume there, and that amniotic fluid is there so the baby can practice breathing movements. It's also there as a protective mechanism against any trauma that might occur to mom's belly. And then we're looking at fetal anatomy. So we're not only looking at the hamburger sign or the hot dog sign to figure out if patient or the baby is a boy or a girl, but we're looking at other things: 5 fingers, 5 toes, 2 eyes, 1 nose. 10 fingers, 10 toes, 2 eyes, 1 nose. We're taking a look at belly size. We're taking a look at head size. All of these things can help us to determine if something may be wrong with the fetus. Assessment of fetal well-being. Once mom has started to feel quickening, then we can have her do kick counts. I think we're going to go through all these in turn. Non-stress test, contraction stress test, a biophysical profile, and then a Doppler ultrasound of the umbilical artery. So I love this picture. I'm sure it's photoshopped, although my husband makes fun of me all the time because I look at pictures of dogs doing yoga and I swear they must be real, but he just laughs at me and tells me they're absolutely photoshopped. So I'm sure this little foot on this mama's belly is photoshopped in there. There's just a little too much structures, a little too many structures between the fetus and the abdomen in order to actually see a footprint, although it would be kind of cool. So what we're looking for with kick counts is 10 fetal movements during 12 hours of normal maternal activity, or 4 fetal movements in 1 hour when the mother is at rest and is focused on counting. So those are normal counts. Anything that veers from normal, and certainly that veers from normal for the patient, needs to be evaluated. A non-stress test, we'll apply an external transducer to monitor the fetal heart rate in response to fetal activity. So baby's moving around, and we're looking at the fetal heart rate as the baby's moving around. So our reassuring signs are that we see two or more heart rate accelerations lasting 15 seconds over the course of 20 minutes. We define these fetal heart accelerations as 15 beats per minute over baseline. So you can see here we have fetal activity, and then as we look up here, mom's baseline is probably right around here, and we're seeing two nice accelerations on this fetal heart monitor that coincide with the movements of the fetus. Contraction stress test measures the response of fetal heart rate to uterine contractions, and so very often this will happen or be tested when mom's in the hospital and is being monitored. So late fetal heart decelerations following half of the contractions is non-reassuring. I don't need you to be an expert in fetal heart rate monitors patterns, but I do think it's going to be important as you move into your OBGYN rotations, that you have some understanding of what you're looking at. So on bottom here, you're going to see contractions. On top here, you're seeing fetal heart rate. So we're seeing a normal range of 120 to 160 beats per minute, and healthy accelerations in response to contractions. And really the contractions here are very, very, very mild. Over here, when we're looking at late decelerations with variability, we have contractions that occur here, and then we have a late deceleration and loss of variability, loss of that. Over here we see this kind of sawtooth line, and here you're not seeing that. And then again, contraction, a late deceleration, and that smooth line. This is a non-reassuring pattern, so we want to make sure we're evaluating, possibly prepping mom for a C-section if this is the case. So for the biophysical profile test, we do several different things: the non-stress tests, fetal breathing movements, fetal tone, amniotic fluid volume, and fetal movement. I would like for you to know what is included in the biophysical profile test. I do not want you to focus on the number of points given for each parameter of the test. So focus on the things that are included, but don't focus on the rest. Do, however, print this slide, put it in your pocket, and take it with you to your OBGYN rotation. Doppler ultrasound of the umbilical artery. You can see blood is moving through the umbilical artery here. This is a good sign, a good thing. Antepartum patient education. So employment. There are very few restrictions on employment. So we don't typically want patients doing strenuous lifting or prolonged standing. But if this is something that they're used to pre-pregnancy, then they can continue. I typically tell patients less than 50 pounds especially in early pregnancy. But that can be very, very hard, especially if you have older kids running around who want and need to be held. Exercise, definitely recommend 30 minutes of moderate exercise, but truly any exercise the patient has been engaging in prior to pregnancy, that patient can continue to engage in that activity. You encourage the patient to listen to their bodies. You encourage the patient to stop if they're feeling out of breath or if they're feeling any pain. But really right up to delivery, the patient can continue a normal exercise routine. Now, this is not the time to start CrossFit, but it is okay to continue. I would modify the weightlifting to some degree, but again, encourage your patient to listen to their body. It is important to encourage patients to avoid supine exercises after the first trimester. This is simply because the weight of the uterus is pressing on the vena cava and can decrease venous blood return, so the patient can be uncomfortable, lightheaded, etc. No restriction on sexual activity in normal pregnancy. Now, if we have a pregnancy where the patient is bleeding, we may restrict sexual activity, but no restrictions in a normal pregnancy. Patients want to know when they can fly, and travel is appropriate up to 36 weeks. You will have some airlines who will require letters from obstetricians, especially if patients are measuring large, if they're carrying triplets and they look like they are way more than 36 weeks. Or you get someone behind the counter who's never been pregnant, never seen a pregnant woman, doesn't know anything about pregnancy, and they see your little 24-week baby bump and they freak out. So not a bad idea just to go ahead and get a letter from an obstetrician saying, yeah, you're safe to travel. Medications, be sure you're giving a list of medications that are safe during pregnancy. There are great apps for that, so encourage patients to use those. Find not only apps for what medications are safe during pregnancy, but also apps for what foods are safe during pregnancy. There are several foods that you shouldn't be eaten. I'm not sure how good the evidence is on some of them, but they came out between my pregnancy with my youngest and pregnancy with my son, and they came out with a recommendation against lunch meat of all things. So of course I didn't eat lunch meat for 9 months. Sushi's off the table. Certain fishes that are high in mercury should be off the table. Soft cheeses are considered unsafe, strong word, risky in pregnancy. Also talking to the patient about alcohol, tobacco, and substance abuse. We've already touched on those things. So common pregnancy complaints, we looked at these briefly, but these are things that patients will come to you and call you about. And, I love this cartoon because the pregnant patient is expected to say, oh, everything's just fine. But typically patients have backaches, constipation, heartburn, nausea, vomiting, acne, aching feet, incontinence, exhaustion, varicose veins, stretch marks, moodiness, and nosy strangers. So I like this slide. And if I don't get back to stretch marks, I think we do later in the course, but if I don't get back to them, stretch marks are largely hereditary. There are thousands of products on the market that claim to reduce the incidence of stretch marks, but really there's nothing that works. You can, let your patients put whatever they want on their bellies, but we haven't found anything that's very efficacious. And what we have found that is, your mom had stretch marks, you probably will too. So blame your mom for everything, just like my children do. So here's just another summary of all the common symptoms during pregnancy, some things that you can do about them. Headaches, acetaminophen in usual doses is reasonable. Patients will have nausea and vomiting. That's very normal. And there are medications that are safe. Zofran is safe in pregnancy. There's also a combination medication that used to be sold, was taken off the market not because it was dangerous, and it's slipping my mind why it was taken off the market, but it was a combination of vitamin B6 and Unisom, the old school Unisom, not the Unisom gel tabs, but the Unisom that that's the hard tabs, and I'll get the name of that for you and show it to you in just a minute. Heartburn, Tums are great. There are some things to do for constipation. The best thing to do is increase fluid intake, fatigue, rest, leg cramps, massage, heating pads, back pain. Heating pads are okay. Maternity massages, varicose veins, keeping the legs elevated using TED hose can help. Hemorrhoids, prolonged standing can increase your risk or severity of hemorrhoids, and then vaginal discharge can be very normal during pregnancy. Okay, let's see if I can find real quick the combination drug that I was talking about. Obviously, I was having some trouble with my QuickTime a few minutes ago, so I think it was under, what was the name of duloxetine? Let's see. So, oh gosh, no, that's Cymbalta. No, that is wrong. So let's look at Unisom and B6 for morning pregnancy. Obviously, I've looked at this before at some point. So, doxalamine. Doxalamine. Yeah, Cymbalta, no, not so much. Although there are some medications, some antidepressant medications that are safe in pregnancy. To be honest, I'm not sure what rating Cymbalta gets for pregnancy. We rate pregnancy medications in classes, A, B, C, and D. And every medication will have its rating in pregnancy. And I hate to give you the parameters of the ratings right now. I'm not spelling Cymbalta very well right now, so I'm not finding the rate of that either. That's a pregnancy risk factor C. So the factor C means that adverse events have been observed in animal reproduction studies, but there haven't been any studies done on humans. So you just need to talk with your supervising physician, or if you're pregnant, talk to your obstetrician or your obstetric PA about what's safe. So back to Benedictine for morning sickness. It's a combination, Benedictine was a combination of peroxidine, vitamin B6, and doxalamine, which is an antihistamine. It's under the brand name of Unisom in the US, and it again has to be the old school doxalamine. So you want to tell patients that they can take 10 milligrams of vitamin B6 and 10 milligrams of doxalamine up to 4 times a day. So that is it for preconception and antepartum care. So thanks for your attention again. Hopefully I'll see you Friday. If not, you'll have these recordings as well, just in case you want them. But be well, be happy, and I will see you as soon as I can see you.